go ahead and get started. Thanks for coming out this afternoon. We're welcome to August's Tracks Data Science Lab seminar. Today we're going to be talking about the Ordr data system. This is a new data system that's meant to provide access to the UNC community to de-identified EHR data. And so we just wanted to take the time today to talk a little bit about sort of the motivation, where it's coming from, what you can do with it, what sort of data is included, hopefully sort of entice you, help you figure out whether or not it can be a good fit for some of your research needs. And so with that, we'll go ahead and jump in. And so I'm just going to start sort of big picture here by introducing the idea of data enclaves. This is really something that perhaps has taken off in the past, I don't know, choose your time span, but maybe 10 to 15 years. And so these are secure cloud-based computing environments, typically owned by whoever sort of, and run by whoever owns whatever data is included in these things. And they're really meant to sort of simply and in one like fell swoop sort of address all the regulatory and privacy as well as legal concerns that people have with sharing data, particularly health-focused data sets. They can host both identified and de-identified data sets. And part of the motivation for sort of making these cloud-based and sort of run under a single technical structure is that you can limit and change what individuals can access. So under a single data enclave, right, you could have a situation where one researcher needs to access identified data, so they get access to that. Another researcher doesn't need identified data, so they get access to the de-identified data. But it's one technical system that you've put together to provide access to people for both of those situations. There tends to be a limited ability to download data as well. Again, this is sort of addressing privacy and technical concerns here as well. The most common, commonly known one of these, at least in tracks, is N3C, the National COVID Cohort Collaborative. This is run by MCATS at a national level. It currently has about 22 million patients in it from 84 different sites. And really, I think if you look at the federal level, this is becoming something that is more and more common. Medicare, CMS is moving to this data. The National Center for Health Statistics is moving to this model as well. And part of this is sort of motivated. There's a 2019 law that sort of encouraged federal agencies to sort of make more data releases happening. And so what these enclaves in a lot of ways are really trying to do is balance this idea of the risk-utility trade-off, where you're trying to balance the risk of re-identification from your data with the utility that's actually associated with that data. And so this was an idea that was talked about in a 2010 paper that I'm showing here. And so you can imagine, right, if you have zero disclosure risks for some amount of data, right, you can, and that's another way that you can think about that is like not having any data. There's also zero data utility in that. So nobody wants to use that, right? And so what these data enclaves are trying to do is trying to find where in this plane can the data that we release exist so that it's useful to people, but also secure. And so where the original data is going to live somewhere up here, such as indicated by this blue dot. There's some maximum acceptable risk that is shown by this dashed line that was moved down by HIPAA. And so somewhere under this dotted line is where the data is going to live. And really the goal here again is to protect the data that needs to be protected while making sure that it's actually useful to people, so that you're not investing in a resource that is not going to be used by people, while also sort of addressing all the privacy concerns that people will have with it. So lots of universities have already figured out and sort of balanced this risks successfully. So here's a sample of existing health-focused data enclaves that are hosted by various US universities. Most of these are supported by the local version of the CTSA, such as here's Tracks. These can be up to like 10 to 15 years old. I think Stanford the one at Stanford I know is roughly 15 years old ago, is about 15 years old. And really, I think the point here is that this really provides the motivation for what this ordered system is. And I think it's helpful to sort of look at this landscape of what other peer universities are doing to recognize that this is not something necessarily like new or novel that we're coming up with. This is a pretty standard way for our peers to make EHR data available to researchers. And in a lot of ways, I think is becoming a best practice in the field. And so that sort of provides all the motivation that has led to the development of this ordered data system. So Ordered is a collaboration between TRACS and RINC that is really meant to provide new health research data focused warehousing at UNC. It's meant to support both education and training, improve access, improve research data security, as well as improving access to research data that you all can use, as well as decreasing the EHR data extraction workloads that can sometimes exist. And so Ordered is not meant to replace the current method of going through CDWH and the TRACS EHR data extraction team. It's really just meant to be an additional tool for researchers. And I think as we go through our conversation today, I think you'll see that there are places where Ordered is going to work for people, and there are other places where sort of the currently existing method is going to be the best option. So let's go ahead and define Ordr. So Ordr stands for the OMOP Research Data Repository that's de-identified. So it's all de-identified data based on the OMOP Common Data Model. I'm showing the full OMOP Common Data Model here on the right. I just note that most of these tables are not actually currently populated in Ordr. And I'm not going to spend really any time today talking about OMOP and sort of what that data model looks like. If you want to know more about that, I would refer you back to the June of this year's seminar that Peter gave. That was an introduction to OMOP. You can find, if you go to the TDSL SharePoint site, you can find a link to all of the past seminars there. If you need help figuring out where that is, any of us can help you figure that out. So it's a bit of a timeline in terms of where Ordered has come from and where it currently is. Really sort of discussions amongst various groups started in late 2022, continued through most of last year, as well as sort of the beginning part of getting all the data structured and formatted and into the right systems. Late last year was when technical testing began. And then March of this year was when the very first pilot proposals were approved. This was a handful of pilot users to sort of get on board and help with testing and figuring out how exactly the system is working and where it can go. And so in terms of where things currently are, we would say that Ordered is operational. You can log in, you can access the data. At the same time, we would say that optimization is still in progress. And because of that, we're really at this point welcoming and encouraging feedback from people. So for example, I think, and we'll talk a little bit about this later, but we're still trying to figure out, right, like computationally, are the memory resources that we've currently allocated, are those enough for what people need? Do we have the correct number of do we have the correct type of packages installed for what people want to do? Do we need to get access to GPUs on here? That's really where we're trying to have a conversation with folks who are using Ordered to make sure that this is a system that works well. Okay, so let's get into some of the details about the data here and what's actually included in Ordered. So in terms of where the data comes from, so it's all UNC EHR data. It's sourced from Epic. The Epic Clarity tables are then transformed to the PCORNet model, which are then transformed into the OMOP Common Data Model. This tends to be the easiest way to get data into OMOP. Data in Ordered is updated roughly quarterly at this point. There's a hope in the future to move to monthly updates. That is still something that we're working on. But I think it is worth noting that it's not a static data set. It will be updated and because of that sort of continue to grow over time. In terms of who all, like what cohort, here's the cohort inclusion criteria. And before we get into this, like the details of who exactly is included, I'd say like the cohort here was designed to be fairly large and broad and diverse, and to represent patients that are more likely to have, or that are likely to have more longitudinal care than the entire EPIC patient population. So first off, the patient must be present in the UNC OMOP database. So if patients who are prisoners are excluded from that database, as well as patients at EPIC Connect practices. And then for each patient, they must fall into they must have at least one of the following two categories in terms of the breadth, perhaps, of data that exists here. They either have to have at least one inpatient or emergency visit, or at least two visits, at least 30 days apart. That's an observation or telehealth visit or a non-hospital institutional visit, or an outpatient visit. And so if they meet both of these criteria in terms of being patients, and then what their record looks like, they will be included in the Ordr database. One final set of work that's done to the database before being loaded into it is going through the de-identification process. So there's 3 steps for de-identification that are undertaken for Ordr. First off, which is fairly standard and probably not a surprise, is just the stripping of all identifiers. So this means that no PHI is in Ordr. All medical record numbers are scrubbed. Each individual patient gets an individual patient ID, person ID is what it's called. And that's how you can track patients and individuals across the database. Step 2 is date shifting. So every event in the database that has a date is shifted by a random amount that's between minus and plus 180 days. But you have a consistent shift per person. And so this means that for each individual, their shift, right, is going to be somewhere between plus or minus 180 days. But every event for that person is going to be shifted the same amount. And so what this means that if you have a project that's looking for relative days between events for a person, types of projects like that are going to be very possible. So for example, if you want to do like procedure follow-up, if you want to know, right, for example, after a certain type of procedure, right, how often do people come back within the next 6 months? You'll be able to do that because for each person, the relative time between each event is going to be constant there. What you can't do is look at absolute dates. And so for an example that we like to give here is if you're interested, or if you want to connect, for example, to like an external data set, looking, for example, at like air quality conditions on particular days, that is not something that you're going to be able to do with Ordr because of the state shifting that's here. Finally, we do some age adjustment. There's a we consider age outliers to basically be patients who are older than 90 years old. And so we shift all of those ages to make them 90. And so if you're interested in geriatric patients who are older than 90 and you need to know exactly their age, that's not something you're going to be able to do. But if you just need to know a patient is at least 90 years old, that is something you are going to be able to do. So those are the steps of de-identification that are taken. Is that a question? Yeah, go for it.
When you strip the identifiers, like identifiers can be pretty broadly depending on, I know who you're talking to, different things are identifiers. Like provider names, are these removed?
Yeah, good. So the question is, like are provider names, maybe locations, those types of things removed? So all things like that are going to be removed. Yeah. Maybe I should say converted into a randomly generated hash. And so you can track, for example, like different providers, where you can track a provider ID, but you can't figure out who that provider is. But you can get their specialty. Is that correct?
Yeah. So there are kind of 2 parts of this. I mean, there's sort of database de-identification theory generally, and then there's practically what happens here. So like if you go all the way back to HIPAA, there's like 19 direct identifiers that truly have a de-identified data set. You have to, have those non-identifiable in some way. The sort of downstream piece though is currently in our OMOP databases, we don't both identified and de-identified. You don't necessarily have all of those identifiers at baseline, just because not all of the tables with all of that information have necessarily been loaded. So the de-identified database has probably the least number of those identifiers at baseline. So the biggest pieces are things like MRNs are salted and hashed. Ages are categorized, right? Like you have a date of birth until you get to 90 plus, and then you're bucketed to 90. Like those things are pretty standard. The like actual service delivery dates are shifted. A lot of the location information just isn't even really loaded in there currently. So like if you have work where you need to know like a very specific location piece of information, like the de-identified data set currently is probably not a good fit for that research. So on the provider side, I mean, you can basically think of it as something like an NPI, but it's been hashed. So like you have integrity in terms of like tracking individual providers. And I would have to double check this. I'm pretty sure we have links out to like what the specialty of those providers are, or maybe even the level, right? In terms of like, what level of LIP is it? Is it physician? Is it a nurse practitioner? I would have to double check that. But you cannot track it down to an identifiable level, like for the provider, or that type of thing.
Thanks.
Yeah, go ahead.
180 days is really conservative. I wonder if there's any reason why it was so broad, because I think in addition to, like air pollution stuff, you also could be completely off on seasonality. Like it would not be able to tell whether something was flu season or not. Why is it so broad?
That's true. Yeah, I might defer to Peter again on that because involved in this discussion.
Yeah, I mean, I think it's just sort of become the standard number that is considered best practice in large scale database data shifting.
I work with 30.
But it's really, I mean, it prevents you from doing a lot of different types of research.
Like, have you considered maybe putting flu season binary variable or something to?
Well, I think it's open to consideration. We're actually working on an environmental linkage project right now that this sort of also came up. Like we were looking at doing date shifting and all of that data, and the standard would have been, positive to minus 180 days. It was like that, like just doesn't work. Like, could we do date shifting but do it as like 10 days?
Yeah.
Like,
it's been a while since I worked with jigger dates, but we use 30 plus or minus 30. I mean, is there some like proof that 180 is better?
I mean, I don't know that we have like a lot of, before I make this statement, I should say like, it's not like my academic area is de-identification theory and validation, right? My experience has been, it seems like this positive to minus 180 days comes up a lot, particularly in very large scale databases in terms of like, well, this is the number that gets used. But I don't know if that points back to some sort of like seminal validation paper in terms of de-identifying dates. But I think it's a good question to ask. And I think it is something that we should think about because, ideally, to the sense of like utility versus security, like we want to basically try to apply the least amount of date shift that you can and still meet the goal of de-identification. I will also say, like, legal and security and privacy has a lot of thoughts on this topic. They're not necessarily completely evidence-based.
Yeah.
And I think we were in discussion for more than a year, just sort of getting this off the ground. So
it's like, I work in cancer, but I actually still care about flu season because it explains so much about like care, like variation in care delivery, like why someone might come to their doctor, that it really matters.
Yeah. I think, again, I would say, Ordr is up, right? Like it is open for proposals from faculty across the university. But I mean, I think these are questions that we're trying to optimize on, right? Like, is the hardware right? Is the software right? Like, is the data right? I mean, the biggest thing that I anticipate is people saying, it doesn't have the data I need. Like, you need to go back and include this data. But I mean, I think this is part of it too. Yeah.
So this gives us these tables, this whole process. So we end up with about 3.1 million patients in the Ordr database. These are the primary tables that are populated and ordered right now. So the person table obviously contains patient level identifiers and characteristics. The visit occurrence table at 193 million rows has information about encounters, counts. The condition occurrence table at 487 million rows has mostly diagnosis information from encounters and build diagnoses and problem lists as well. The drug exposure table, 270 million rows, has all inpatient and outpatient medications from Epic, including immunizations, prescriptions, administered medications. Let's see, the procedure occurrence table is 80 million rows, has mostly inpatient and ambulatory procedure information. The measurement table is the largest one here at 1.3 billion rows. It's a combination of labs and vitals for both inpatient and ambulatory settings. The observation table, 327 million rows, sort of a catch-all table in OMOP for things that don't neatly exist in other tables. But there's things in here such as, they tend to be sort of like patient-focused, such as there's some social determinants of health information, some health history. You can sometimes find marital status in here, those sorts of things. And then finally, the device exposure table is 37 million rows and currently only contains information on mechanical ventilation. To give everyone a better sense of sort of what this database looks like, I'm going to spend the next few slides sort of breaking it down at sort of a high level along a couple of different axes here. So first, we can just look straight at demographics. Roughly 45% male, 55% female. Roughly 60% identify as white, just under 20% Black or African American. These demographics roughly match the population of North Carolina as a whole. If you're interested in birth year, so here I'm showing the shifted birth year. So this is including the plus or minus 180 days. And then number of patients in the thousands that have that birth year. And so you can see, unsurprisingly, because of that shift at greater than 90 years, right about 90 years ago, you see a big spike in terms of the number of patients that have that listed birth year. And you can see this goes up into minors are included in here, right? So we have shifted birth years all the way until last year. If you're interested in just sort of diagnoses in terms of how many are included here, so this is shifted birth year against the number of diagnoses. I would just point out that I'm plotting this on a log plot. So late 80s, early 90s, you're talking about just a few hundreds, sort of rising up into the thousands and tens of thousands. There's a pretty big jump in the early 2000s when you start getting up to millions of diagnoses per year. And then ending up, right, if you look over the past, I don't know, maybe 10 years or so, you're looking at roughly 10 million diagnoses per year in the States.
It's worth pausing here too, just to point out, for those of you that have been at UNC a long time, so obviously Epic started April of 2014. So this data includes the pre-Epic era back to the legacy WebSys EMR.
Is this just UNC Hospital, or does it include like the affiliate systems?
So it should include the affiliate systems, right? Yes.
So it includes all the hospitals as they come online, right? Because it's not like everyone started in April 2014. Even as a hospital, a satellite or community hospital is acquired, or we sign a management agreement, there's typically a delay that can be short or long before they go on to Epic. And then I don't know if we have a systematic policy about bringing legacy data in from those institutions. Yeah, I mean, the one piece that is not in here are, I think Josh said, so prisoner population from Department of Corrections, And then also UNC's Epic Community Connect partners. So those are clinics that have basically signed a contract to use our Epic EHR install, but they are not part of UNC. We're basically, I understand it as like, we're a secondary provider of Epic to them.
Is there another question?
Semi-related, and you almost answered it. It was around WebSys versus Epic, and my experience asking a tracks analyst to pull data from WebSys, it's incredibly challenging. They're just, the data are just very messy. And so I'm just curious if you were to even want to get data past Epic, is there, I'm sure I can give this guidance, like don't even try to get vitals, for example, or, you know, I just fear like the granularity rapidly diminishes.
Yeah, I mean,
Or y'all found a workaround perhaps.
you could have a lengthy conversation on this topic. I mean, what I will say is the pre-Epic data that's here is coming from something called ADS, which was essentially an old data warehouse for like the combination of legacy systems from Siemens and from Centricity and from WebSys, like all of those different things. So that is sort of, if it existed in that ADS data warehouse, it has the potential to come in here. It's not like we can go back to like all of the original source systems. But even then, I would say you probably don't want to try and like write an R based off of the pre-Epic data. I mean, we had a conversation about this during design and build, and some of us were kind of against bringing it in because you're not totally guaranteed 100% of the data. It's a little bit unknown. And there was a feeling of like, it's already an experimental system. Like, let's bring in what we can and see if it is valuable and useful to people. And so what I would say is what was brought in pre-Epic was basically the stuff that like, we think this is pretty complete. We think we can get to this. And we can easily bring it into OMOP, right? So things like definitely diagnoses. I think things like that go into OMOP measurements, which would be labs, vitals. I think some portion of those pre-Epic come in. I imagine that's in an upcoming slide, looking at measurement.
Yes.
Yeah.
No, I think I did not go into the.
Okay. But yeah, so it's just going to be some portion of the stuff. So it's there. I think we would love for people to look at it and figure out, is this valuable and complete for certain areas? But yeah, I wouldn't like write an entire, grant portfolio banking on getting access to that data in really granular detail. Yeah. At least at this point. Does that answer your question?
If you are interested in particular types of visits, here's a breakdown by the visit type. So looking, right, so for most of these types here, you're looking at hundreds of thousands up to maybe a few million. Outpatient visits, you're looking at roughly, I think just over, I believe, about 100 million. Let's see, this is from the drugs table. So this is in terms of millions of records included here. Administered records is what makes up most of the drug exposure table. And then you got about 35 million or so procedures and immunizations, and about 50 million prescriptions. Final little bit of characterization here. So we've gone ahead and calculated both the Charlson and the Elixhauser comorbidity indices for the whole Ordr database. And so I think these are mostly meant to be illustrative of sort of what sort of these distributions look like. We're going to talk in a few more slides. We'll talk about sort of why we're including these. And so in terms of like technically how this is all provided, that's a lot on the database itself. The technical structure here, It's all situated under a framework called Helix, which was developed by Rincy. It's a technical framework that takes care of basically all the cyber infrastructure. It's really geared towards a lot of heavy data use intensive cases. It wasn't developed just for Ordr, but is a very good fit for it. So basically, you access Ordr by logging onto a remote desktop. Helix provides sort of the framework. And then there's actually 4 applications on once you sort of log in here. One's a file explorer. So I didn't show that here because it's not very interesting. In terms of actually interacting with the database, you have 3 options. So pgadmin is a Postgres SQL client. And so if you're familiar with SQL, which actually to use Ordr at any level, you're going to have to be at least somewhat familiar with SQL. You can use pgadmin. And then RStudio for R users and Jupyter for Python users. Both of those come loaded with like pretty much all of the standard data science data use heavy packages such as tidyverse, pandas, numpy, scikit-learn. We haven't run into, right, I shouldn't say that. If you run into situations where there's a package on here, a package not already installed on Ordr that you really, really want to use, you can feel free to go ahead and request that. It'll take a little bit of time. It has to basically undergo security review to make sure that package isn't trying to get data out of the system. But then we can sort of provide that to you as well. 2 other questions we get in terms of sort of interacting with the data via Helix. Basically, like, how can I add in my external data that I want to sort of map to this Ordr database? And then also, how am I going to get data out of here or data products out of here at the very end? And so the current process is as follows. Basically, get in touch with the Ordr team. Depending on what exactly you're trying to do, there'll be some hopefully short sort of review and technical work, and then you'll get approval for that. Again, I think sort of going forward, this is something that we hope to streamline quite a bit. But this is sort of the current process for what things are looking like. One thing that we're working on fairly actively in the data science lab is getting a set of supporting resources up and available for all users. And so the plan is to make these available on our GitHub as well as within the Ordr system as well. And so we found just by talking through people and experience that a lot of people are going to ask for Charleston indices or Elix-Hauser indices. And so we're basically computing these for the whole database as they exist, and then we'll make them available. There's in the future, when we're just starting work on these, we hope to have a number of sample computational phenotypes available in here. The 2 that we're working on right now are both diabetes related. I think what comes next is going to depend on conversations we have with the sort of Ordr user community in terms of what's going to be helpful. But really, I think the goal, like the data science lab goal in terms of providing these resources is that we want people to be able to get up to speed as quickly as possible. We don't want you to having to spend a lot of time figuring out how you can sort of do the basic things of getting into the data. We want you to be able to use your time actually sort of answering your research questions. And so we're working just to provide as many as we can resources to help that go as smoothly as possible. Yeah, go ahead.
For the comorbidities, what date are they based on?
So that's an active discussion, and I think there's a couple of sort of ways that we're going to actually implement this. I think one that we definitely will do will provide sort of date range for like an entire patient's lifespan. And then the discussion part here is, do we provide sort of a way for individual researchers to say, hey, I want dates between this date and this date, have that as sort of a user input that then it can go calculate that for.
Yeah, that seems important.
Yeah. So I think we like to say sort of like Ordr is a good fit for 2 particular like things here. If you want or need quick access to EHR data, de-identified EHR data, Ordr is a great fit. If you can answer your research question using de-identified data, right, I think this is in a lot of ways going to save you time and money by not going through the data extraction process. It's also going to give you a lot of flexibility in terms of having control over iterating, right? And so, right, if you're trying to figure out what exactly, right, like your cohort inclusion criteria are going to be, right? Ordr is going to be a really easy system to be able to go through here and say, right, okay, try this, now try this, and be able to see what those results are going to be basically. And finally, the second part here is definitely you need some technical knowledge in Python, R, or SQL, or a teammate who does. That's how you're going to interact with the database, along with sort of the what's computational setup is. In terms of getting access to Ordr, there is a very short proposal. Proposals have to be submitted by UNC Chapel Hill faculty, so they currently can't be submitted by graduate students or postdocs or other or staff. A faculty member has to submit it, but then the members of their team can be granted access. You basically need to come up with 5 things here. 1, a title for your project. 2 short paragraphs, basically explaining what are you going to do with Ordr and how is Ordr going to help you with this. And then you have to have upload proof of your human subject training as well as UNC HIPAA training. And so when I say like for 3 and 4, when I say short, we like literally do mean short. So I have an example proposal here. What that time? I think for the sake of, this is like literally what we're looking for, right? Roughly a paragraph, right? We want to show that like you've thought about what you're doing, what you're trying to do here, and how Ordr is going to be helpful for you. So 2 paragraphs is basically what we're looking for. The proposal review process basically covers 2 things here. 1, what I just said, that you've shown some thought into what you want to do. And then 2, we just want to make sure you're not doing something crazy like trying to identify patients. So the proposals are reviewed at the monthly CDWH Operations Committee meeting. This means that depending on when exactly you submit your proposal, you should get a response within about a month. And then we should be able to get you set up and going on things pretty quickly after that. So I am going to show a quick demo here for sort of relating back to sort of all the privacy and legal requirements. You can't actually screen share the ordered system itself.
Hey Josh,
Yes.
even before you go into the demo,
Yes,
could you just go over to the SharePoint site to the ordered page?
I can go to the SharePoint site to the ordered page if I can find it. You want to put it? Can you do that? That would be great.
Yeah, I think Kara's just dropping it
Okay.
in the chat.
Yeah, perfect. I can copy it and get it over. Let's see. I logged in. I'm logged. Good.
Yeah, and so this is, we have different levels of access within this. Everyone with an onion has access to most of this. There are portions of this that get into connection details and some other things that only people that have an approved proposal have access to. But for the most part, all of the links that you see here in terms of general information, FAQs, even if you go back up, and then go on to ordered pilot info. So here, there are even deeper links, as well as, sort of quick stats on the cohort, links to the proposal form, and then go to ordered documentation. So everyone should also have access to the ordered documentation, where we're working on building out sort of more details to a lot of the relevant specs on this. So this is, like, as you can imagine, a lot of people have a lot of questions, and we're trying to centralize as much information as we can on the SharePoint with general onion authentication. Yep. Yeah.
You mentioned that the provider and stuff are hashed. like, does that mean that I can tell if like a group of patients were all treated by the same provider because they have the same hash? Or in the same location, like at the same ED or something?
Yes, anything that's been obfuscated is gonna be obfuscated like
The
at
same way.
that whatever that level is.
So I could figure out, like, if I looked at a bunch of ED visits, I could figure out that these were at this ED and these were at this ED.
I just can't remember what we've done on location currently, because it was not the highest priority to get in. Providers, yes, like that should be in there. Locations, I can't remember if locations are in there. Locations are there, then the answer would be yes. Like you should be able to see that everybody was treated at location A.
Yeah.
Exactly, yeah.
The one other thing, there's I think this is sort of behind the login page, but there's lots of technical documentation on here too, about how to sort of get started. So this is what I can show today is what's called OMOP in a pod. It runs on sort of the same Helix interface. So actually, the interface once you get into Ordr is exactly the same as what I can show you here. Just the data set that's included here is a synthetic data set from CMS. So it's a SynPuff data set if you're interested in that. So let's see. So you can log in. So OMOP in a pod has both Jupyter and RStudio. So I've already just launched a version of Jupyter here. And so I'm going to show you just two quick examples here that are really meant to give you a sense of like how you can like sort of the like technical details of how you interact with the database and maybe sort of some like things that you can do with it. So we load all of our packages. We connect to the database itself here. Down here, I have a couple of like what I like to call helper functions. And so this is another example of what we're working on providing to everyone in Ordr. Where basically what this does is you feed it your query of what you want to put in, what you want to pull out of Ordr. You give it some column names, and it's going to return to you a pandas data frame that's all neatly organized and ready to go. And so again, the goal is to hopefully help people get off the ground relatively quickly. And so that means I have an example here. So this is my first query. I'm just going to pull everything. This is just the database name from the visit occurrence table. So I just write out my query in SQL as a string. I put it into this function that I just defined up above. Because I'm pulling the whole table down, I'm going to tell it my column names are none, and my function is going to go figure out what those column names are, and they're going to put it in here. And so you can see here is our synthetic visit occurrence table with the visit occurrence ID, the people IDs, dates, and other things that are included as well. For the sake of sort of showing you sort of like something you might do what?
Care site ID.
Yeah, so care site ID is something that is included in this one, yeah.
That sounds like a clinic.
But this is also a different database.
Yeah.
This is our synthetic.
Okay.
Yeah.
Yeah.
I missed that part.
Yeah, OMOP SynPuff data.
So for the sake of interest, I just said I'm going to go pull out all visits that correspond to person ID equals 1. I can look at what, so in OMOP, the visit concept ID is what tells me what type of visit that person has. So I collect all of those together. I see there are 3 different visit concept IDs here, and these are their frequencies. I write another query then, right? Because so let's say, right, I want to know what these visit concept IDs actually are. What are people going to what do these visits correspond to? And so I go to the concept table. I pull out these concept IDs, right? And I can see that some of these visits have no matching concept that's listed. Then I think these are reversed, but 1 inpatient visit and 2 outpatient visits for this particular person. Speaking of care sites, actually, this will be my last example. Then we'll wrap up here. And I thought of sort of as just a sample question you might ask, right? Is looking at care sites, right? Do particular care sites tend to treat patients that have like different birth years? Just as sort of an example here. So I pull out the care site ID, I get the person ID, I'm getting the year of birth. This comes from a couple of different tables, the visit occurrence table as well as the person table. So I have to join those two tables together using the person ID. This is what this particular query returns this data frame, which has roughly 47,000 rows in it. If I want to look at just like the number of care sites that are in here, I see there's about 20,000 different care sites that are included in here. Just for the sake of visualization, I just picked the top 10 of those. So looking at the sort of the top 10 most visited care sites in here, I pick those out, and then I can create a box plot of what that looks like. Let's see, not going to go down to that last one, but you can see, relatively few lines of code to get sort of care site ID, and then box plots of what sort of the birth here. And so I think, again, like the point here, even though it's not sort of the exact same Ordr data set that is available to you all now, is meant to sort of just give you a sense of how you sort of might get started interacting with the database itself. Okay, and so I'm just going to put up these takeaways and sort of open it up for questions and discussion. Any other things that would be helpful to chat about?
So I can just add, I'm just looking at the actual Ordr database right now. Care site ID is included in our visit occurrence table. But it is essentially hashed or otherwise obfuscated into a random 32 character string. And that maps onto a very general care site concept, which we have 54 distinct concepts like hospital outpatient mental health center, hospital outpatient cardiology clinic, hospital-based outpatient clinic.
So it could be like Rex Hospital or UNC Hospital.
Correct.
It's not
There's no identification of
more
what it
specific.
is. It's just what type of thing it is.
So it's more like a department.
I mean, maybe not even a department, but it's like a facility type, and if it has a sort of like specialization associated with it.
But not unique to that facility, like it could be a group of 20 different facilities that all fit that category.
Correct. So, for instance, like skilled nursing facility is one. Like that could be any skilled nursing facility, or let's see what's something that has a lot. OT. OT has a ton, but that could be OT at any of like the various clinics or hospitals in the entire system.
And then from the visit table, can I link back to the problems or to the diagnoses, for example? Is there like a key that allows me to?
Yeah, everything is relational.
Okay.
Yep.
Yes.
In the chat, does the EHR data set have maternal health data?
Yes. Yes is sort of the short answer.
Yeah, it might depend a little bit on what the specific maternal health data of interest is. I guess it's worth saying just sort of categorically, the data that's in Ordr is sort of what you think of as off-the-shelf OMOP data. So it has information about the person, then it has diagnoses, procedures, measurements, which in sort of OMOP parlance means lab results and vitals, drug exposures of various types, and then observations, which currently observations is basically a lot of like patient reported outcomes information, like standardized assessments that psychometric or otherwise that patients are taking in clinics, usually clinics or hospitals.
But also labs and stuff too, right?
That's in measurements.
Oh, measurements.
Labs and vitals are both in the measurement table in OMOP.
Sometimes there's a few things that are classified a little bit unusually in OMOP. And we recently on N3C, we recently went through a version update of OMOP that moved things from one category to another. So some things might sometimes not be quite in the table that you would first expect to find them. But usually they're fitting those descriptions.
And we do have a lot more documentation coming out very soon, specifically for OMOP and how we implement it here at UNC. So not Ordr related, but just how Trax does OMOP. So all the documentation is going to be focused for research audience specifically, and probably coming in the next couple months or so.
I can't remember which table I looked for hemoglobin A1C measurements first in Ordr, but it wasn't in the first table I looked. So I remember that much. So I was expecting it in one table and it was in another. I forget if I tried measurements first or observations first.
Yeah, I mean, honestly, as the group that governs OMOP and the OMOP vocabulary, like they do some things that are helpful and make sense. So for instance, like medications, typically, especially in something like a claims data set, you just sort of have to know that if you need 100% of medication exposure, you need to look in like a Part D file and also a procedure file, because there are going to be a lot of medications that are administered as procedures. And OMOP does something that's arguably kind of helpful in that they just move all of those medications into one drug exposure table. But then they do some things that are a little bit counterintuitive. For instance, they take a terminology like ICD diagnosis and they break it up into different tables. So some diagnoses go into the conditions table, but some they call observations. So if you need to see 100% of what you would think of as ICD terminology diagnoses, you need to look at different tables. But I mean, something that I consider part of our infrastructure is really the build out of views and things to sort of help with that knowledge. So like I have a view where I just union everything together. So you can just scan for whatever codes or concept names you're looking for. I don't think we would necessarily expect a researcher to just know like how the OMOP vocabulary works or how their governance structure works. So, part of that is what I consider the data science lab's responsibility in terms of building out infrastructure to help facilitate people in navigating these pieces in like OMOP and in Ordr specifically.
Right. Two other questions. One that you can probably help with. So question, are microbiology lab results included?
If they're a lab results, so, if it's like looking for the culture of a specific microorganism and it's run through, the clinical labs and it's something that would get, coded by like the LOINC terminology, then yes, it will definitely be in the measurement table. Particularly if it's something that's like run through UNC's labs. There might be some very rare exclusions for things that get sent out for labs or sent to third-party labs that gets a lot more complicated. So like in the past, this has been an issue with things like complex genetic analysis, where we don't do it. We have to send it out to other labs to do it. We don't necessarily, at least in the past, we don't necessarily have 100% of some of those results. But if something is a lab, the chances are good that we have it. Because just on the 3 million patients in Ordr, we have over 1 billion labs. That is fairly comprehensive in terms of like the labs that are getting ordered in the clinical setting.
Then one other question, could you talk about the IRB approval perspectives for gaining access to this data set?
Yes, I'm glad. I didn't think of this, but this is a really important aspect. So I'm glad somebody brought this up. IRB approval is not required for projects in Ordr. This was another lengthy regulatory conversation that we had with the IRB. And the IRB was very clear on this, that as a fully de-identified data set, projects do not need to go in front of the IRB and be reviewed or approved for access to the ordered system. They It is de-identified data. It is outside of the purview of the IRB.
So human subject research.
The determination is they do not want to see these projects come to the IRB.
Sounds like they're calling it a blanket exempt.
Okay.
Yeah, the caveat to that is they say anything can come to the IRB. And it might be recommended to do that just because of the downstream. If something gets to the point of publication, it's nice to be able to click the box that you do have IRB approval or exemption, and this is the IRB that has done it. But for actual, like, if you are simply proposing a project and want access to the system, the proposal does not go to the IRB and does not get reviewed. It just goes to CDWH Operations Committee currently. Yeah, so that is a very big difference between ordered and doing work in ordered compared to getting access to identified or limited identified data sets from the CDW. I guess another piece that is maybe not totally clear, but several people have asked me this is, like, what is the sourcing, or like, does this get data from the CDW? So the data in ordered is sourced from the same data as the CDW. You can consider them parallel databases. Everything is essentially sourced from the EPIC databases, the Clarity database specifically. So EPIC Clarity feeds into what people call CDW or CDWH. EPIC Clarity also is what feeds into Ordr. So it's all data coming from the same initial database, sitting behind the EPIC EHR for UNC.
One question about radiology, and most of the results are very much a text, a paragraph. Is there a way to get that into Ordr or
No.
Okay.
Yeah, so at this point, the only data that's included is structured data, and specifically the limited structured data that's sort of both high priority as well as capable of being de-identified. Currently, the stance is that unstructured data, particularly text, simply cannot be completely de-identified. And so at this point, like, notes of all types, notes and reports are basically outside of the scope of Ordr. Yeah. Imaging data has come up on that same vein, but currently, imaging data is outside of the scope. I mean, maybe it's worth saying there's been related questions on, say I want to do a pilot. Like, several people, if you're familiar with I2B2, have tried to relate Ordr to I2B2, and they've kind of said, like, can I get fast access to Ordr to pilot something, or to get patient, cohort magnitude, and then use that to then create an identified data request? And the answer is yes. Whatever you do, it would be relatively, trivial work, insignificant, to take the code from Ordr and put it into a data request to go against our identified OMOP database. And for the most part, the code should run almost as written. So, like, if you take the time to identify cohorts in Ordr, you could then pick it up and turn it into a data request against the identified Ordr database and run that through the EHR data team and get, a full identified data set back from that.
There's another question. Could you state in a manuscript that it was exempted by the IRB at UNC?
I don't know if it has not gone in front of the IRB. My belief is you probably could not say, but that's probably something we'd have to get clarification on. Yeah, I mean, the conversation that I had with IRB was that projects didn't need to come. They would still consider recommending it, as they do for any project, to basically get called NHSR, not human subject research. But I believe if it hasn't even gone in front of them, you don't have the ability to call it NHSR, and probably not also to say that it's exempt. The difference might be if the IRB was willing to give a blanket statement of any project going through here we're willing to call exempt. But my understanding is I don't think we have a blanket statement on that today.
I have another question.
Yeah.
Can I find in the EHR data the patient's some baseline information like the socioeconomics data or the lifestyle information like smoking or alcohol, can I find them in the data?
I mean, it probably depends specifically what you're looking for. So for instance, there are social determinants of health information collected in sort of a couple of different ways that would be in the observation table. But it's just a question of, is it exactly the type of data you're looking for related to, say, like socioeconomic status? So for instance, like I know someone has asked me about employment, like, can I get someone's employment? No, you can't. Or can you get like someone's address history at various levels? No, you cannot currently. So if you're looking more for like patient self-reporting, like you have trouble, paying for food, like you can get that for some, maybe even most patients that respond to those questions as structured data. But yeah, I think it just really depends on like what specifically you're looking for.
So it depends on what was the patients reported when they went to the clinic.
For the social determinants of health data, specifically in Ordr, yes, yeah.
So if the patients reported them and they are recorded, then you didn't filter them out.
No, like that information will be in there.
Okay, thank you.
Yeah. Yeah.
Great. Okay. Well, any questions, feel free to reach out. Thanks for coming this afternoon.